Thank you very much, Inde, for inviting me to have the privilege of chairing this afternoon's session with your colleague, Dr. Sunil, and with a particular focus on optimising care for bones, education and awareness. So if you'll just give me a few minutes, if you don't mind, I'm going to give you a potted history of the interaction that I had. Names have been changed, and it is a brief summary. So Mrs. Williams, as you know, GPs now often do phone triage, and I was asked to ring Mrs. Williams to give her her recent pelvic and hip x-ray report. She'd had a fall back in December where she'd sustained a fractured femur, imminent fracture, as we've heard this morning. But the hip had continued to be painful. So her GP at the time had referred her for an x-ray, and I was ringing her back, and she'd actually sustained an avulsion fracture of the greater trochanter. However, when I rang Mrs. Williams, she was quite surprised to hear from me. She said, wow, why is the GP practice ringing me? I'm in Glangwili Hospital. Well, why are you in Glangwili Hospital? Well, I fell yesterday and I fractured my hip. She subsequently had a total hip replacement. So I was curious, and I just went through her records. Mrs. Williams is a 62-year-old lady who had a BMI of 30, non-smoker, asthmatic, several exacerbations, hypertensive, had a diagnosis of SLE, and under the care intermittently of a rheumatologist, has a hiatus hernia and ischemic heart disease. She was diagnosed with osteopenia in 2017 following rib fractures from coughing, an infective exacerbation of her asthma, and was commenced on vitamin D3. She's also under immunosuppressives for her SLE. She takes regular prednisolone and has frequently, up until more recently, had high doses of steroids to manage the SLE. Her fall, which was a slip back in December and led to hip pain, did result in that fractured humerus. She's on vitamin D. She has had one DEXA, which was waiting another one, which was requested over a year ago. So I could go on that, and I've actually maintained contact with her more regular GP at that practice just to see what the outcome was. She has subsequently been discharged with a total hip replacement and is awaiting follow-up and care from her rheumatologist. And I'm only sharing this not to point fingers of blame at different bits of the system, but actually to demonstrate that it is a system issue and the problems are right across the system. People, for so many reasons, fall between the cracks and only attend our services in a reactive and not a proactive way. And in a practice, this particular practice is hugely reliant on locums, reducing access to continuity of care and the really important relational care that a good GP provides. This in a system where access to timely diagnostics is limited due to increasing demand and thwarting capacity made even worse after COVID. So there's so many points along Mrs. Williams' journey, and I didn't go back too far, where things could have been different, providing us opportunities aplenty to change the end of that story when we look back in anger. This afternoon's presenters will take us through various aspects of Mrs. Williams' journey and her pathway and highlight the importance of our roles, each and every one of us, across the whole system in maximising bone health for our population. So I'm going to hand over to Sunil now, who's going to introduce the first few speakers. And I was really interested, so Inde, thank you for introducing me to Sunil, colleague and friend of yours, who's travelled 4 hours yesterday to be with us today. And if you don't mind, I'm going to ask you to just share a little bit of your career history, because I found it very fascinating. Thank you.
And good afternoon, everyone. So I'm sorry I'll be taking about 3-4 minutes of the presenters' time this afternoon, but what I thought is, I don't know if you have had this bedtime story. I mean, this is a very popular one when I was a child about, and I used to listen to this from my father, and it's a bedtime story on people going off to see an elephant blindfolded. And I think what I'm going to share with you the next few minutes is roughly my experience through my career on dealing with, shall we say, the elephant, which is it's a big challenge we are facing in our society around osteoporosis, fragility, fracture. So I started my career as an orthopedic surgeon, and For 12 years, we had a small group of orthopedic surgeons. We nicknamed ourselves the Trauma Warriors. And other than doing some relatively good fixation of hip fractures, I don't think we went beyond managing the patient, beyond that fracture fixation. And I can say with certainty the only difference that happened in the 12 years of working as an orthopedic surgeon was that we started having trauma lists. We didn't have that. I remember operating at 11 o'clock at night on hip fractures because we had to do it. So I don't think a lot has changed, or a lot changed while I was an orthopedic surgeon. I then decided to switch careers, and I think that was the first blindfold of my eye, and I became a GP. And I think this is where my story of shame and guilt at the poor care that we provide to patients after they have been in hospital starts. Because when I looked into my GP practice, which is a fairly big one, 15,000 patients, we had only 3 patients on the osteoporosis register. So that's when the work started, and we built up in the practice a really good, fracture identification, follow-up kind of program within the practice. Then joined hands with a few other practices which thought likewise, and then turned it into a local, at that time called the Clinical Commissioning Group in England. That we started a program, and that's when I got into the business of commissioning. So the thought process there becomes very different. Yes, there is focus on the patient, but there is also focus on what are the benefits to the system. So that took me to the realm of business case, return of investment, policy, and things of that like. And a brief stint with NHS England also helped in understanding. So at each step, you can see a blindfold coming off, because we sometimes work in our silos thinking, well, I'm doing all this, nothing else is happening. And I think as individuals, we need to think beyond that. And then finally, I took over as the national lead for the senior clinical lead for the falls and fragility fracture program, which kind of encompasses all the things that we are trying to achieve here. And I think Wales, on this side of the border, you're doing much better than the other side, in that at least you're making such a huge effort. I'm not saying it's not happening elsewhere, but I think you can be looked at as an example of how we need to do things. And I think what we need to think about is a joined up care, because we have heard speakers this morning that, from different specialties, dealing with different things, the fact that osteoporosis and fragility fractures don't work under a specific specialty. I think we need to really think about joined up care in all ways, including administrative. And I think what we also need to think about is not just a 12-month review. We need to think beyond that, and I think that's where FLS is probably the place to start. But I think what we need to think of is what goes beyond, because this is part of a long-term condition, which, because it's not there on paper, we shouldn't be ignoring it. And I think that's the message I have for everyone. We really need to think beyond just the 12 months of care. Thank you. And with